Tell me, how many psychologists are in the audience? Okay, very good. How many psychiatrists? Okay, excellent. Any nurses? No nurses. Okay, interesting. Usually the majority of the audience are nurses at these talks, so it's interesting. Any social workers? Okay, very good. Any clergy? Okay, chaplains, as part of that. Interested lay people in the topic? Very good. Excellent. Who have I missed? Counselors. Very good. Okay, counselors. Excellent. Family doctors. Okay. Physicians. What was that? Creative arts. Yes. Excellent. Occupational therapists. Excellent. Okay. Now, what I'm going to ask you to do, I'm going to ask you, this is a very controversial area, this area of religion and health. Okay, and not everybody sees things the same way in this area. There's a lot of, different ideas about this. And what is the connection between religion and health, and how are you going to use this practically in what you do in your practice? A lot of questions about this. Should this be done? Why? So, therefore, what I'm going to do first of all is ask you what you want to get out of this evening. What questions do you want to know about? What are some questions that you have? So I'm going to open this up. We're going to take questions first instead of last. And then I'm not going to answer your question, but I'm going to ask you to write it down, get some kind of scratch paper, wherever you can find it, write it down, and then I'd like someone to collect those scraps of paper so that at the end, I'm going to leave about a half hour to 45 minutes in which I will answer those questions. So, the topic area is religion, health, research, and your questions. You can, I tell you what, raise your hand if you have a question. So say it out loud first before you write it down. Say it out loud first. Yes, sir.
What are some ways you find most helpful to promote spirituality and integrate whatever degree of spirituality you can promote with healing? And the more specific, the better.
Okay, very good. Okay, write that down. We'll pass it to the front. Next. Yes, Michael.
Noticeable differences in an effect size in various areas of health of religion. In other words, was religion a better preventative in cardiovascular illness than it is in some other area?
Okay, good. Excellent. Write that down. Yes, sir.
There's publication bias in the reporting of results and studies of the relationships between religion and health outcomes, and if so, in what direction and in what areas?
Okay, fine. Again, get that down on a piece of paper and hand it in. Yes, sir.
Spirituality, religion is a very huge field. What particular aspects of spirituality and religion do you find helpful in healing?
Okay. What particular aspect? Excellent. Good. Again, write that down. Yes.
How do we distinguish between religion and faith?
How do you distinguish between religion and faith? If you can distinguish them, how do you do that? Okay, very good. Again, get it down. So I have it to look at. I can look at that and then answer it. Whatever you got. Yes, ma'am.
What does the research say about the connection between spirituality or religiosity and the development of positive mental health in children?
In children, okay. Religion or spirituality, and its development of positive mental health in children. Good. Get it down. Yes.
What do you think of research studies about the efficacy of prayer in healing when there's also the idea that God sometimes says no?
Okay. We'll talk about that. Very important topic. Yes.
I'd like somebody like you and MD to refer to when I talk to my believers and friends in church about the connection between health and spirituality, and not just the spirituality and health is something totally different. And I also like somebody to refer to that when I talk to non-believers about health and spirituality.
Okay. Form that into a question and get that written down. Good. Yes. Okay. Yes, sir.
What are, in your view, the ethics of refusing necessary treatment on religious grounds, transfusion, things of that nature, and secondarily, refusing them for children of whom you have guardianship and authority over?
Okay, fine. Refusing treatment on religious grounds for yourself and for children. Yes.
How do you make religion useful without getting bogged down in differences of belief?
How do you make it useful without getting bogged down in differences in belief, in practice, applying it in counseling or wherever? Yes, good. Yes.
Is all religion beneficial to your health, or maybe some specific aspects? Like, is there a difference, for example, between Christianity and other religions in the benefit of health, or is it just religion that's beneficial to your health?
Okay, fine. Good question. Get it down.
What are your observations on using health as a selling point for religion, the ethics of using health as a selling point for religion?
Okay, the ethics of using health as a selling point for religion. Okay, get that down. Yes.
You notice a gender bias among medical practitioners as to their openness between men and women regarding spirituality, connection with religion, and
Whether or not men or is there a difference in men and women in their openness to addressing the spirituality issues of patients? Good. Okay, write it down. Yes.
In your book published last year, there's a chapter on the priorities for future research. Could you please update, which including the areas for further research, research methodology, especially in terms of methodological issue, in terms of meta-analysis? How have you found out any way to solve the issue about like heterogeneity and things like that?
Okay, write that down. Write the question down. It's a very important question, especially for a researcher. In the back.
I've run across lots of people who've had toxic reactions to various denominations and so on, or to their particular religious experience. I'd be interested in what research says about the percentages of such people and the influence of both their individual constitution of personality and the groups that they're part of.
That's good. That's good. Write that down. These are wonderful questions. We're going to be here till tomorrow morning answering them too. Yes, in the back.
It's the reverse. Is there any research that sometimes religious beliefs get in the way of optimal health? Because sometimes if they go the way the belief system predicts it will go, can actually create more stress.
Sure. Good. Write the question down and pass it to the middle, because that's a good one. Those questions, I've got to have those questions written down, so write it down. There's a question there? Yes, sir.
What's the relationship between intercessory prayer and healing, and does the effect size increase with number of people praying and length of time praying?
Okay, fine. Good. Okay, any more? Yes.
I was just thinking about, do you have to be open to spirituality, religion? What about atheists, agnostics, whatever, in terms of their being able to be helped by this reality?
Okay, get that down in a question. Now, let me be sure. Let me sure I get this.
Well, it's if you're spiritual, if you have a spirituality, if you're religious, I could see utilizing that with people. But how about if you're, in other words, it's only going to be for the believers, or is there something beyond belief of the individual that will help promote his or help him with it?
Okay. Okay, fine. Articulate that in a question. Okay, good. Okay, very good. Well, let's move ahead, and I'll answer perhaps some of the questions in the presentation. I'll kind of go quickly, though, through here. So I'm so glad, though, that you have wonderful questions. You're really thinking. I appreciate. A lot of times I'll ask that question, there'll be silence. I mean, silence for a long time. But they did a study on this, and they determined that after 45 seconds of silence, the silence is so intolerable that somebody has to ask a question. They can't stand it anymore. It's usually, though, the speaker that ends up breaking the silence because they can't stand it anymore. But anyway, 45 seconds. Remember that if you teach. Okay, could I have the first slide? Okay, well, this is about religion and health, and this is Duke University. This is our chapel, the University Chapel. You can go right up to the very top there and kind of stand there, and you can look all over the surrounding area. It's a beautiful chapel inside. And then right next to it is Duke University Medical Center. And here's our life flight helicopter. And so religion and medicine, how are they connected? Okay, next slide. Now, let's look a little bit at this historical connection, because it's important to see where we are now with respect to where we have been or where people have been in the past, because a lot of times you kind of lose that historical connection. Now, we understand how things are now in terms of health care, how we provide health care to the sick. And we almost consider that to be, like it's always been that way, that we've kind of always provided health care to people who needed it. And in fact, that was not the case. And up until about the 4th century, there were no hospitals anywhere in the Western world. No hospitals of any kind. If you couldn't afford a private physician to take care of you, or if you didn't have family members to provide care, you were out of luck. You could die. Then for but was they did kind of the religious, kind of spiritual practices and rituals. That was how they got their healing, because there was. So the 4th century, the first time hospitals are built. Hospitals are built by the church, by religious organizations. Over the next 1,200 years, the church would continue to build and staff hospitals throughout the Western world. And certainly in Canada here, again, I'm not very familiar with what's going on in Canada, but you know, I know you have a lot of hospitals like St. Mary's and those kind of hospitals. Those are still kind of the remnants from the past. Kind of started and staffed these hospitals. Many of the early physicians in Europe were, in fact, ministers or priests. And in fact, the priests were interested in practicing medicine, apparently because, you know, it was so close to what they were doing. They were dealing with the person's emotional and spiritual issues, and then the body was I mean, it was all kind of like one. A person was just like a person, and part of those needs were their medical. So they were so interested in medicine. In fact, the church had to pass an edict that said that they couldn't do that because, you know, they had to, you know, spend most of their time in their religious duties as opposed to practicing medicine. So a lot of them practice medicine, but you can just see the kind of the connection there. Now, in the United States, this is a very clear connection. In the early colonies were basically doctors as well, simply because they couldn't afford to raise their families on just the salaries that they got from being a minister. So they practiced this medicine on the side, so to speak. And they received that training in Europe a lot of times before they even came over to the States. The first nurses from the beginning were the sisters, were the religious nuns, first nurses. The first formal nursing order was called the Daughters of Charity, St. Vincent de Paul. And even in the United States, the first nursing order was in Emmetsville, Maryland, again started by the Daughters of Charity. That continued up until the early 1900s. Most of the hospitals were staffed by the religious, the sisters or the nuns. Also, there were the deaconesses from the Protestant side coming out of Germany. Lutheran pastor trained the deaconess. So you have the deaconesses and you have the Catholic sisters up until the 1900s. That's kind of what who provided the nursing care. So that kind of surprised me. I'm a nurse. I'm a nurse from background. I have a nursing background. And I remember when I went through training, the nurses had these little white caps. I don't know if they still wear them around anymore, but some hospitals they have those little white caps. I was always wondering, where did those caps come from? You know, I was glad as a male nurse I didn't have to wear one of those. I had this blue smock on that I felt kind of ridiculous wearing, but anyway. Where did that white cap come from? That cap came from the habit of the Daughters of Charity. Daughters of Charity wore these big winged white kind of, that was part of their habit, that eventually got shrunk down to the little cap that the nurse wore. So it is kind of interesting, all these different connections. Even psychiatry in America, you know, you think of, you know, psychiatry, geez, how separate that is from religion. But yet, early psychiatry in America, the first form of psychiatric care was called moral treatment. Moral treatment was the first kind of form of compassionate care for the mentally ill. Now, up until then, the kind of treatments the mentally ill were getting were not terribly compassionate. There would be bloodletting. They would draw blood, you know, or they would give people repeated enemas. And it was, you know, after those kinds of practices, you know, the mentally ill, sure, they would kind of calm down after you drew off enough blood and after they were dehydrated enough. So they were effective to some respect, but they also locked the mentally ill up in boxes, basically. The Utica crib is an example of it. It was kind of a see-through coffin-like apparatus. It was locked, and the mental prison would be placed in there, and then it would be locked again. They could kind of see the person through the slats. So William Tuke then in England said, hey, forget this. Apparently he had lost a friend, death in one of the hospitals in England at that time. So he said, to heck with this, there's got to be a better way. So he developed what was called this moral treatment in York, England. And so it was called a York retreat. And what they did is they had a wonderful kind of home-like atmosphere. It was on a farm in the country. It was rolling hills, a little lake, a fireplace. And they would bring the mentally ill person in, and they would treat them as a civilized human. And they would meet their, there were moral or spiritual issues. They would talk to them about that. They would treat them with compassion. They were expected to go out and work on the farm. They had chickens and cows, and they would collect the eggs and milk the cows and do all of that stuff. And so all of that helped to kind of get their life back into order. It was very nice and regimented, so it brought order back into the life by constructing kind of a peaceful environment with order. Had very remarkable success with this. And then it came to the United States with the Quakers, because, see, William Tuke was a devout Quaker, and that was why he did that. And so it came to the United States with the first psychiatric hospital in the United States was called Friends Asylum, which is still today in Philadelphia. And it's still, I believe, I'm not sure if it's may just be, kind of a Friends Hospital. Is that right? Very good. So it still is there admitting patients. I'll be darned. So up until really then in America, the mentally ill were primarily confined. They were kind of separated. Even at Pennsylvania Hospital, for example, they had like a place where they confined the mentally ill. And that was before Friends Hospital, came about. So in any case, this was pretty remarkable. And so here the first psychiatric institutions in America were these kids were oftentimes Protestants, were often early, and it could be Quakers. The chaplain lived right on the grounds of the psychiatric facility, lived right there, to provide not only the services, but also some of the counseling. And in fact, the early these were some of the people who founded the American Psychiatric Association. Samuel Woodward, Amariah Brigham. They were the co-founders of the American Psychiatric Association and the journal, the American Journal of Psychiatry. So it is interesting how our founding forefathers in American psychiatry were quite attuned to religious influences and the benefits of religion. In fact, patients were even rewarded for good behavior by allowing them to go to those chapel services. That was their reward for good behavior. Now, come forward about 80 years to Duke Hospital. Duke Hospital, 80 years, more like 150 years, to Duke Hospital about 10 years ago, when a chaplain or clergy person could not visit a psychiatric patient without a written order from the attending physician. So the clergy were basically, at many institutions, Duke in the South, Methodist institution, still clergy could not see a patient on the psychiatric ward. The psychiatrists were worried they would destabilize them in some way, whatever. So how did we get there? How did we get from moral treatment with the integration of the clergy to excluding the clergy completely from the care of the mentally ill? Next slide. Well, Dr. Freud did have a role in it. He was a very powerful speaker, and he had very strong feelings about religion. And he did ultimately say that his feelings about religion and his teachings were different than his teachings about psychoanalysis. that they were not part of his teaching in that regard. It was completely separate. It was mainly his opinions in that regard, although, you know, it eventually kind of got mushed together so that this future of an illusion became kind of the main kind of declaration of psychiatry's feelings towards religion as being a universal obsessional neurosis. Like the obsessional neurosis of children, it arose out of relation to the father. Historical residues have helped us view religious teachings as neurotic relics. We may now argue that time has probably come, as it does in analytic treatment, for replacing the effects of repression by the results of the rational operation of the intellect. So you can kind of see that Freud was very, very strong about this. He had many books, not just this one. There were about 4 or 5. In fact, the last 10 years of his life, between the ages of 72 and 82, he wrote, you know, several books about this topic. And it wasn't just Christianity; it was Judaism as well. He didn't like either of them, basically. Although he came from a very devout, well, not a very devout, but his father was a fairly devout Jewish man. Was not?
Never devout.
The father?
Oh, the father was son.
I mean, he used to wear, you know,
Yeah, the father was son.
But Freud was, and then I heard that Freud turned back to religion in his later years, but I heard also that was not true. So, anyway. Okay, next.
He always identified with it as an ethnicity.
As an ethnicity.
But he never bought the religion.
The religious belief and faith part.
He referred to himself as a
Godless Jew. That book, right? Isn't there a book by that title?
That's Freud's original, that's only his own words.
His own words?
Yeah.
Interesting.
Correspondence and stuff.
Yeah, that certainly confirms. Okay, now we know as therapists, we have therapists here, psychologists, counselors, we know that religion can be, you know, used neurotically. I mean, we see patients who are using religion defensively in all sorts of different ways. We know that it can be used to justify hatred and aggression, of course. Can be used to gain power and control over other people. Can be used to justify prejudice, of having the truth. Everybody else doesn't have it, so you feel better about yourself, you know, self-esteem issue. Fosters rigid thinking, obsessive practices. So Freud was right in that some people can use religion as a kind of cloak to conceal their obsessive practices, and they may appear very devoutly praying 4, 5, 6 times a day, and yet being unable to do otherwise. Used to deny the facts, magical, unrealistic kinds of beliefs. Interferes with medical care. There was a question there with regard to, you know, accepting blood products or rejecting care for oneself and one's loved ones. That certainly occurs. Can be used instead of medical care. A healing service may occur, and the person may decide, well, I want to demonstrate my faith, and I'll do that by stopping my medicine, you know, as a way of demonstrating faith. Delays diagnosis and effective treatment. Person may decide, well, I'll pray about this lump in my breast, or have, you know, instead of going to see my doctor, because I really don't want to know what that thing is, but I'm certainly willing, I'm going to pray about it, you know, and so then it can delay diagnosis. Can be used to justify non-compliance. Yes?
I'd like to add something on number 4, that it can reinforce the fears and conscientiousness in people like Andrea Yates, who killed her babies because of her fear of hell and damnation, and schizophrenics who will gouge out their eye because of thoughts of evil. So it's a variation of 4. and why some doctors say, I don't want clergy coming in to Duke Hospital without my vetting who they are, because some clergy do that kind of stuff. They scare the hell into patients.
Yeah.
So I'm not so sure that free access of clergy is necessarily a smart thing. Generous access, but a little bit of vetting might be a good idea.
Yeah, yeah. Makes sense. Makes sense. So, definitely religion can be connected with neurosis. Now, part of the question is it the religion that is causing the neurosis, or is it neurotic people who are using religion? You know, that's the question. So let's take a look at, well, actually, next slide. Now, the treatment for religious neurosis. Here he is watching his TV. Are you plagued by doubt? Do you question the existence of God? Is your faith challenged by the vicissitudes of modern life? Do you think the church is full of phonies and hypocrites? You may suffer from general spiritual anxiety disorder. Try Prozac, the exciting new over-the-counter pharmaceutical 9 out of 10 ministers recommend. Okay, next. Well, here's another one. It says, the end of the dog is coming. This is, he's saying to him, or, you know, sometimes I wonder whether there really is a dog. Next slide. Okay, now let's get into a little clinical activity here. Let's look at this patient who is 83 years old. This is a medical patient. We're going to now kind of look at people who are not necessarily psychiatrically ill, but patients who are oftentimes may have physical illness, but are generally mentally intact. Because I think a lot of the research in the early days upon which some of these negative opinions about religion were based were primarily based upon kind of the clinical experience of seeing mentally ill people, not of studying mature, healthy populations in the community. So let's take a look at one of those patients. This is not a patient of mine. This is actually a patient of a professor at Harvard. In fact, is one of the editors of JAMA. And this professor was not religious. However, this particular patient so impressed this doctor that they decided to do a clinical crossroads on this patient. And it's actually coming out in 2 days, the 24th, July 24th. It'll be in clinical crossroads, this patient. So let's look at her. She's 83 years old. She has multiple serious medical problems. Chronic, progressive, unrelenting pain. She has chronic pain. That pain is with her almost all the time. Traditional medical treatments are not effective. She's tried everything that the Massachusetts, Harvard medical system can offer. They are not effective. She's apparently also narcotic resistant. So she has narcotic resistant pain. She can take all the Demerol or all the, Percocet or whatever she wants, but it doesn't help her pain. It just makes her, kind of puts her out. But it doesn't relieve the pain. She's tried alternative medical treatments. She's tried acupuncture. She's tried massage therapy. She's tried the various kinds of, herbal preparations. Not effective. She has limited material resources. She lives alone. She's not very well educated. She's kind of living in this high-rise, kind of senior living situation. Doesn't have much money. But in the 12 years that this doctor has been seeing this patient, she's doing well psychologically. despite all these medical and social problems that she has. She's positive. She's optimistic. And in fact, she's functioning entirely independently. She doesn't have even a home health aide come in to help her with all this chronic pain, this disability, this progressive weakness. Not only is she functioning independently, but she's concerned with meeting other people's needs. She gets in her wheelchair, goes to the hospital, and she's praying with these other patients to, provide them comfort and hope. And so she's concerned with others' needs. How does she do it? The doctor says. She says, how do you do this? I don't understand. She says, it's because of my religion. Now let's look at some of the words that she uses. Next slide. Now, talk about meaning. I think you will be able to see a lot of meaning in here. Some people are really sick and going to doctors and hospitals, and still they stay the same way. So I think praying helps a lot, but praying without belief is no good. You have to believe in what you are doing. I know I believe in God the Father, the Son, and the Holy Spirit. I believe in God. He's my guide and my protector. Next slide. These are words right out of the JAMA article. I don't dwell on the pain. Some people are sick and have pain, and it gets the best of them. Not me. I pray a lot. I believe in God. I give my whole heart, body, and soul over to Him. It's very important to see how this woman's life is turned over completely to God in her faith. This is not just kind of a peripheral interest of this gal. This is her whole life. Sometimes I pray, and I'm in deep, serious prayer, and all of a sudden my pain gets easy. It slackens up, and I drop off to sleep, and wake up, and I can do things for myself. So prayer helps me a lot. I give God my heart and soul. And you don't have to worry about nothing. You see, people with chronic pain, of course, have all of this muscle tension, from the pain, and it's guarding kind of. So this helps her not to worry, these beliefs. Gives her life a sense of meaning. So it helps her not to worry. He leads you and directs you. He takes care of you. And I believe in that. That is my belief. Next slide. Now, there are a lot more quotes in the article, so just look, Journal of the American Medical Association, JAMA. I think it's Wednesday, it's coming out. General medical, now how common is this? So when you study people with medical illness, these are not psychiatric patients, you find that this is not all that rare. I was surprised 15 years ago when I was a young doctor and I was kind of had been a nurse, and so I was interested in how people were coping. That's why I was really interested. What did these older people who had lived a whole lifetime learn from all of their experiences, sometimes through the Depression, sometimes a World War? What had they learned? And now that they were older and facing some really tough stuff like cancer or stroke or heart disease, how did they cope? So I would say, well, what enables you to cope? And so, a lot of people would, gals like this lady here would show up. And so I was impressed. So I thought, okay, well, I think we ought to do some systematic research and see how common this is. So that's when I started. My first studies were just systematically asking random samples of medical patients, older adults, what enabled them to cope. And then that's kind of how my research got started. Now, there has been a lot of research actually been done over the last 20 to 30 years on this topic in all of these different diseases. And whether they're older adults or whether they're younger adults with AIDS or HIV, cystic fibrosis, ALS, severely ill adolescents, you find a lot of depending upon religious and spiritual beliefs to help people to cope. A lot. Even in places like the West Coast, you see a lot of this. For example, in Southern California, you see quite a bit of it. In arthritis patients, older arthritis, the number one form of coping in older arthritis patients in Southern California is prayer. Number one of all the list. It sits right up there at the top. Yes?
A couple of quick points. The reason we said it in California is that the entire West Coast, essentially, of the United States is an unchurched belt. If you look at the stuff that Tara puts out, where they color counties by how many are unchurched, essentially the whole strip, Washington, Oregon, California, and talk in Nevada, the most unchurched areas of the United States. So the findings, in fact, among a population of unchurched is all more intimate.
That is interesting that you have, you find, okay, and we'll talk more about this too with regard to some of the European countries where it's even less. I mean, they're not just unchurched, it goes beyond that. Okay, next slide. Now, again, in the United States, how common is this? Now, you may say, okay, now this Dr. Koenig, I'm not sure about his methods. Maybe he's doing this sleight of the hand here about national random sample published in the New England Journal of Medicine of the American population after September 11th. 1 week after September 11th. The most common form of coping, other than talking to somebody else about it, which, who didn't talk to somebody else about 911, was turning to religion. 9 out of 10 Americans turned to religion to cope with the anxiety, the sense of loss of control that those terrorist attacks caused. In fact, the church attendance in the weeks following September 11th went up to 60%. 6 out of 10 Americans were in some kind of, religious service or in those weeks following. Now, of course, after about 4 months, it went right back down to normal again, but anyway. It is interesting how, in response to stress and anxiety, a loss of control, you see religion peaking, and then as that stress goes away, religion starts to become of less interest, the motivation factor. Next slide. Now, let's look at the types of spirituality quickly in the United States. There's humanistic spirituality, about 7% of the population, kind of the focus on the human spirit. No higher or higher power, no claim. Very highly developed ethical system. Albert Camus, Ernest Hemingway. This is humanistic spirituality. This kind of refers to, I think, your question about 7%. About 7% are unmoored spirituality, which means that the spirituality is not moored to an established religious tradition. Tends to be upper middle class, maybe higher than 7% on the West Coast, because it kind of came out of the West Coast. Sometimes called New Age spirituality as well. Tends to focus on the self, not particularly religious or institutional, energy, connection, nature, crystals, healing, touch, astrology, parapsychology, are sometimes words that are used with this form of spirituality. Then there are the moored spiritualities of the Eastern and Western types. Eastern type is Buddhism, Taoism, Hinduism, not Islam. Okay, this is wrong. This belongs down here. But it's about 3% of the population would be of the Eastern type of moored spirituality. And quite different from unmoored, because this is based within, again, millennia of tradition and of careful kind of religious practices and also accountability in some respects as well, which is not present so much in this form of spirituality. Taoism, Hinduism. Western type 1 and type 2, about 85% of the American population, probably 90%, maybe 85%, would be 25% evangelical, conservative Protestants, Catholics, Jews, and Muslims responsible to someone. This is a theocratic belief system, prayer specific and directed. John Wimber, the God who intervenes, faith healing, anointing with oil, etc. Then there's the moored spirituality of Western type 2. All of our lives are under God, don't expect specifics, pray for God's will, much less likely to discern God's will. Now, believe it or not, these groups are not nearly as distinct these days as these categories would suggest. You see these kind of overlapping to quite a degree. Episcopalian, Presbyterian churches are having healing services, etc. And some of the evangelical groups are more also praying for God's will, also in a situation, as opposed to being adamant, that they be healed. Next slide. Next. Okay, how effective is it? How effective is this? Now, most of the research has been done among the moored spirituality type 1 and 2. Not a whole lot of research, particularly longitudinal research, on new age forms of spirituality. We don't really know a whole lot about that form of spirituality. We know much more about the more traditional religious beliefs and practices, and so that's kind of what this will refer to. We're talking about religion here, okay? The word religion, which I'm broadly defining, okay? I'm broadly defining religion to include not just church attendance, but also religious practices, private religious practices such as prayer and scripture study, etc. Level of religious commitment, level of religious faith, so to speak, in this broad definition of religion, kind of relationship with God kind of thing, all part of religion. And that's what we're going to talk about now in looking at these courses. Now, this is based on the handbook. You've got it right there, right? The Handbook of Religion. Hold that up there so everyone can see it. Handbook of Religion and Health. It has 1,200 of these studies in it, okay? And 850 are on mental health. And so this is the studies done in 100 years of the 20th century. Doesn't include the more recent ones, and this research is increasing. If you just went to American Psychological Association meetings, you know that, I think they're coming up, but last year's in San Francisco, they had a bunch of poster sessions, there were a lot of papers being presented. It's that way, it tends to be an increasing. But okay, let's look. Now, these 850 studies were divided into 3 groups, okay? One group, there was no association. Another group there was a significant negative association. And then there was a significant positive association. So these 3 groups of findings, and many of these studies really just included religion as kind of a factor to kind of compare it with the general population. They weren't looking at the effects of religion on the mental health. A lot of times they didn't even comment on the relationship found in the paper. But if you look at these studies, you find the following. Of the 16 studies on purpose and meaning in life, 15 show that the religious person has greater purpose and meaning in life. Now, most of these studies many of the studies are among people with health problems, with chronic illness, etc. So a lot of purpose and meaning in life appears to be derived from religious beliefs. Now, Freud even said this. he said, the one thing that he said nice about religion was that he felt that the primary source of purpose and meaning in life came from religion. Although he didn't think that life had any purpose or meaning, but if it did, it came from religion. And I forget which book that is. It may be Civilization and its Discontents that's in. But, okay, depression and its recovery. 2/3 of the studies show that the religious person is less likely to become depressed and more likely to recover from depression when followed over time. Now, interestingly enough, this is not just true in in religious areas of the country. This is also true, and we're going now to Europe, where, again, the belief and when you go to Europe, if you look at Norway, and you look at end-stage cancer patients, you find that only about 50% of those patients even believe in God, and 60% derive no comfort or support from their religious beliefs. So now let's look now at Europe, at some of the studies. A guy by the name of Brahm from Amsterdam, he's been doing these studies of the Netherlands and following aging populations there, and also looking at Europe in general, all of the European countries. Adrian Brahm. What he has very nicely been able to replicate is that those people who find religion to be very important are significantly less likely in later life to be depressed. And they are also, now this is not only the Netherlands, this is also the Euro-DEP study, the Euro Depression study, which is, 10,000 people, many of the country. Less likely to be depressed if they were more religious. More important, when they identified those who were depressed and followed them over a year, they found that those who said that religion was very important to them were more likely to be well at the end of the year. This was especially true, now we look at the sex differential, among women. Among women who were religious, very religious, at the end of the year, 50% had recovered. Among those who were not very religious, 0% had recovered. 0%. This is in Acta Psychiatrica Scandinavia, which is like the American Journal of Psychiatry for the Scandinavian countries. Okay, let's see. Suicide. This also reflects in the suicide rates. About 2/3, about 90% of studies show that the religious person commits suicide less often, has more negative attitudes towards suicide, etc. We look at the positive form, rather than looking at pathology like depression, let's look at well-being, hope, and optimism. Of the 114 studies, 91 show the religious person has more well-being, greater hope, more optimism. Now, get this handbook of religion and health, because all 1,200 studies are in the back. They have a single line for every study. It has the authors, the population, the method of sampling with a random, systematic, convenient sampling, has the size of the sample, has the makeup of the sample, has whether it's older adults, younger adults, blacks, whites, has the area it was done in, the city and the country, so you know exactly what part of the country. So you can go down a column and you can find, okay, well, India. You can find India, and you can look at all the studies on mental health in India that have looked at these relationships. Then gives the religious variables, the finding, what was controlled, and then a quality rating from 0 to 10 for each study. So check this out for yourself. Now, anxiety and fear, about half of the studies. Marital satisfaction and stability, about, again, 80 to 90%, 35 of 38 studies. Find that the religious person who, goes to church with their spouse or whatever, is from the same religious background, participates in these practices together, has more satisfying, stabler marriages, statistically significantly more satisfying and stable. Social support, virtually all the studies have shown that the religious person has more social support than the person who is less religious. And apparently this kind of social support is more durable and is of a, well, the correlations with well-being appear to be higher if it comes from a religious source. And also, when you're looking at when people get sick and they're unable to provide support to others, kind of the way most of our social support works, it's a transaction, okay? You scratch my back as long as, I'll scratch your back as long as you scratch my back. But when you are no longer able to scratch my back, I might scratch your back for a little while, but, that gets boring, and I'm going to stop scratching and find somebody else who can scratch my back. That's kind of the way it works. But see, with religious support, those people are not necessarily doing it because they want to do it. They're doing it because they are called to do it. That is what is expected of them because of their religious beliefs. So they are more likely to persist on doing that even when the person cannot reciprocate. So it is interesting as you look at elderly populations, how that works. And we'll get back to that in a little while. Yes?
Has there been any research on the difference between the religions that see the personal contact with God versus the religions that have much more of we are a community, and it's the community that holds you? Because I'm thinking of your time, and the Protestant Catholic is the research that was done 100 years ago, and he was saying around suicide, the more community-based religious following had less suicide than the ones who felt the relationship was a personal relationship.
Right, because the Protestant Catholic differences in emphasis. Not other than, the work that Durkheim did and the suicide rates, not really. Because I think it's so diluted, because you've got so many different, Catholics who are just, like in name only, and so it dilutes out the Catholics that are really, into the community and really, so, and the same with Protestants in some respects. So you don't really see differences when you look at just denominations. It's more and we'll take a look at, actually the next slide, let's see what the next, well, before we go to the next slide, substance abuse and delinquency, you can see there's a massive amount of research looking at the connection with substance abuse. Go ahead. Say that again?
Durkheim apparently fudged his data.
Durkheim did?
Yes.
How interesting.
The book is like there was a question as to whether the title of the book, Suicide, refers to the action of his professional career. But in fact, Greeley has done some stuff with the General Social Survey, looking for precisely sort of communitarian, transcendent, immanent differences.
What did they find?
And he finds them. He gets about a huge percent of the variance.
That's interesting.
Solution. But just about any of the Catholic community, I reviewed the stuff in Floyd's Handbook of Religious Experience. I reviewed Greeley stuff. And so there would be a quick source to that. A lot of Greeley stuff is on this very issue of, that Catholics are more opposed to suicide because it's a violation of a personal religion, of a personal relationship, for example. Those so really has been using the profits from his fiction stuff to fund questions on the General Social Survey to do research.
Interesting. Yeah, that's good. Those general social surveys is a very important source of data because it's a national sample of thousands of Americans, so it's very useful. And I think they had in the 98 module, or maybe 99, or maybe 2000, they had a big religion module that the Fetzer Foundation funded to include in it. So there's a ton of religious data available now on the national samples, at least in the United States. Now, of course, here in Canada, there have been a couple of studies looking at depression and anxiety, and they are not as clear-cut as this. In fact, it looks like church attendance is associated clearly with less anxiety and less depression, but it looks like the personal religiousness tends to be related actually with a little higher. So I'm not, part of that, you're not sure, these are cross-sectional studies, you're not sure whether these people who are depressed and anxious are turning to religion because they're anxious and depressed, or whether, the religion is causing the depression and the guilt, etc. You just don't know that because they're cross-sectional. But it is interesting. There's somebody that I'm working with, actually Marilyn Betts, here in Canada, at University of Saskatchewan, who has got a couple of studies that she's published, one recently and one coming out. Okay, next slide. Okay, now you're correct that some of this research is not done very well, and part of it has to do with you can't control everything your researchers do. So I've reached the conclusion, gentlemen, that the Wonker-Wiener Company is riddled with incompetence. Okay, next. Okay, now, what are we measuring? This is one of the things that we tend to measure a lot. It's the Hoag Intrinsic Religiosity Scale. Now, my sense of this is not necessarily really measuring intrinsic versus extrinsic religiosity. We got into a discussion with our fellows on this. Really, it's more like a religiousness scale. And you've got these 10 items, and you basically just say, okay, to what extent is this true of me? Is this definitely true of me? Does this tend to be true? Is it unsure? Tend not to be true? Definitely not true. So you just read the statement, and a person gets, 1 to 5 score, and then it's from 10 to 50. And then you can correlate this thing with various things. So my faith involves all of my life. In my life, I experience the presence of the divine. Although I am a religious person, I refuse to let religious considerations influence my everyday affairs. That's scored in reverse. Nothing is as important to me as serving God as best I know how. My faith sometimes restricts my actions. My religious beliefs are what really lie behind my whole approach to life. Think back to that patient. And look at these questions. This really does kind of characterize this patient fairly well. One should see God's guidance when making every important decision. I try hard to carry my religion over into all my other dealings in life. Although I believe in religion, I feel there are many more important things in life. That's scored in reverse. Doesn't matter so much what I believe as long as I lead a moral life. Scored in reverse. So you have a nice scale. Next slide, let's look at some outcomes. Next. This is looking at speed of remission of depression. These are all medical patients, not psychiatric. You're looking at, they're all diagnosed with depression using a standard NIMH diagnostic interview schedule, and then they're followed over time, and then predictors of speed of remission are examined. There are 5 independent predictors in this population of about 90 depressed people who are followed. See, this is a probability of non-remission. This is what's called a Kaplan-Meier survival curve, but it's applied rather than to physical survival, it's applied to the survival of the depression. So you can see that the survival of the depression is a lot shorter among those who are highly religious than it is among those who have low religiousness based on that scale. That's independent of social support, independent of severity of medical illness. All of those things have been controlled for, independent of family psychiatric history as well. Next slide. This is looking at an elderly population, about 800 older adults in the community looking at well-being. And again, the red is the intrinsic religiosity, and you can see that well-being increases in almost a stepwise fashion with increases in intrinsic religiosity. Now, if you're looking at this scale and you say, well, there's not much difference here, this is actually average score per item. So that's why these differences are small. They're actually, if you look at the 17-item scale, you're going to kind of multiply these differences by 17, and you'll actually see the difference, the quantitative difference. But it's very statistically significant, and again, maintains that significance when social support, financial status, and physical health are controlled for. Next slide. That is now 14 years old, that study. Actually 15 years. Okay, now, the way our mind functions does influence our body. That's what we're learning. We're learning that the mind influences the body and that these psychological things can influence physical health. So let's kind of take a look at that. Next. Testing whether laughter is the best medicine. Next slide. Okay. This is out of Scientific American. This is that article that kind of looks at the physiology of stress and what that does to your body. And we know that stress adversely affects your physiology. Okay, we know that. We're getting to know that better and better. In fact, they've been actually able to identify using electron microscopy the nerves going right into the lymph nodes, right into the bone marrow, into the thymus and the spleen, the heart of the immune system that connects kind of the locus ceruleus, which becomes activated to these immune cells. So what happens is when people are stressed out, they're angry, they're bitter, they're resentful, they're depressed, they're anxious, they're bored. Boredom is a source of stress. It activates this part of the brain, very deep within the brain, actually in the brain stem. So we kind of have this in common with like all of these lower animals. Also, it activates the hypothalamus, the hormonal system, which ends up releasing cortisol from the adrenal glands, as well as adrenaline, etc., which circulates around and does the same thing to the immune system. It kind of suppresses it, reduces the immune functioning. And so that's not good because you need your immune system to prevent infection, to prevent cancer, to prevent the cancer from spreading. You need your immune system to heal your wounds. If you have a surgical operation, a wound is healed by the immune system. People who don't have a strong immune system, the wound does not close. This is true in older adults and younger adults, including medical students and dental students in which these studies have been done in. So when people are stressed out, that is not good for the body. See, it's okay for the body. In fact, it helped people to survive in the old days, in the caveman days, where a bear was going to attack you or a lion. But, when this developed, it figured, you were either going to escape it or it was going to eat you. You were not going to, you're not going to sit there thinking about that bear or that lion for weeks, months, sometimes years, ruminating about it, like we are able to do. And so consequently, this system wasn't really designed for humans in that sense, because we have this tremendous capacity to dwell on and to be, to hold these grudges against people. Next slide. Okay, so now what we have is we have a medical model for understanding how religious and spiritual beliefs can influence a person's physical health. We're not depending necessarily on there being a God. Okay? We're not depending on that. I believe there's a God, but you don't have to apply this model. This is an entirely science-based, rational, objective model that the rationale is that religion does facilitate coping and helps to reduce stress. It also facilitates social support, which itself reduces stress, enhances immune function, etc., and also influences health behaviors, which results in less smoking, less alcohol use, which itself enhances immune functioning, etc., resulting in all these diseases. So that's kind of the model. That's the model. Next slide. Now, if you simply look at how often people are hospitalized, you see this model kind of plays out. This is a study of about between 400 and 500 older adults and looking at their rates of hospitalization based on their religious attendance. Okay? And you see that those who are never attending religious services have significantly higher rates of hospitalization compared to those who are attending once a week or more. Next slide. Here we are with this intrinsic religiosity again, coming back. Same sample, finding that the average number of acute hospital days in the previous year is significantly correlated with intrinsic religiosity. That 10 to 50 scale is divided into quartiles, and very simply the average number of hospital days are plotted. You can see, average number 5 to 6, average number 9 to 10. Next slide. This is the prospective part of this study. Again, 455 elderly patients, looking simply at the average number of hospital days at Duke Hospital based upon their religious affiliation. And I can see all of you straining to see what your religious denomination is. Okay, now who is okay, actually there's no difference here between the Jewish and the Catholic. That's not statistically significant, so that's just fluctuation in the data. However, the average number of hospital days back in the early 90s was 10 days at Duke Hospital for somebody with any religious affiliation, compared to 25 days. This is the average length of stay. This is an acute hospital. This is a tertiary care medical center. So there's an average of 14 days difference between people who are affiliated with any religious group and those who have no religious affiliation. Yes?
Correct me if I'm wrong, but according to the data, that could mean only 10% of the U.S. population, and maybe we should characterize that 10% if that's the group that are showing up there as the 25 hospital days, or is this just the real church-going type that makes a third of the population?
No, I think you're right. I think these nuns right here are probably that 10% of the population that are not religiously affiliated. That would represent that 10%.
We need to know the characteristics.
We do. What's interesting about this, we did look at this, the characteristics. What we found, this will blow your mind, is that when you control for physical illness severity, this correlation goes up. It goes up. These people are actually healthier than these people, but they're staying in the hospital longer. Part of it may be because they're getting their social support. These are all older patients. Their social support is with the doctors and nurses there. They don't want to leave the hospital. They don't have that support like maybe some of these people have in the community. I don't know. I mean, that's just a guess. Anyway, next slide. Now we go on to look at physical health here. We look at immune functioning, mortality from cancer, blood pressure, heart disease, stroke, cholesterol, cigarette smoking, exercise, overweight, mortality in general. We find that 5 out of 5 studies now show that the religious person has measurably better immune system functioning. Studies are done at Duke, at Stanford in breast cancer patients, large study at Johns Hopkins, now being done using a prayer intervention, a hands-on prayer intervention, you believe that, going on. Mortality from cancer makes sense then, 5 out of 7 studies show lower rates of cancer death, lower blood pressure in 12 of 14 studies, less heart disease in 11 of 16 studies, less stroke, 1 of 1, lower cholesterol, 3 of 3, less cigarette smoking. If that was the only one that was significant, you could understand why, religious people have better health. More likely to exercise. 3 of 5 studies actually show that. Less likely to be overweight. What happened here? 0 of 6 studies. We'll just pass over that, not discuss that particular correlation. But lower mortality and longer survival. About 75% of the studies show the religious person tends to live longer. Next slide. Now, these are not the greatest of studies. They're not all beautifully well designed. Many of them weren't even designed with the intention of looking at religion on the outcome. But when you have this number of studies in many different populations, these are national samples, these are local samples, these are on the West Coast, these are on the East Coast. They're all finding about the same effect size with regard to, they're looking at church attendance. Most of them are looking at church attendance, involvement in religious community. So it is interesting that tends to be the strong, we're talking about, what tends to be the strongest predictor, effect size? It's involvement in religious community. Going to church, the biggest effect size. Even in Canada, even in Canada you see that in the national sample, I think one national sample in terms of mortality is going to church. Now, immune system functioning, looking at interleukin-6 levels and church attendance, you see that these interleukins are lower. This is a Duke study, 1,700 randomly selected people over the age of 65, suggesting the immune system is working better. Next slide. Next. We're going to go fast here. Blood pressure, diastolic blood pressure in almost 4,000 people. Those who are attending services once a week or more and who are praying daily or reading scriptures daily had significantly lower blood pressures compared to those who are going to church less than once a week and praying or reading scriptures less than once a day. So there is a measurable effect. It's very significant even after controlling for smoking, education, race, sex, age, physical functioning, and body mass index. Next slide. Next. In a Jewish population, 10,000 middle-aged men in Israel followed for 25 years. Look at the effect on death rates from coronary artery disease after controlling for blood pressure, diabetes, cholesterol, smoking, weight, and baseline heart disease. There is a 20% difference in mortality from coronary artery disease. Next slide. 6-month mortality following cardiac surgery. This is done at the Dartmouth Medical Center, 232 elderly patients. You find that those people with high religiousness and high social support have 1/14 the mortality of those with low religiousness and low social support. That's after being controlled in a multivariate model, after controlling for the biological risk factors of survival following open heart surgery. Next slide. This is our Duke study looking at 4,000 people followed for 6 years. This is simply looking at church attendance once a week or more. Again, a Kaplan-Meier survival curve. Once a week or more compared to less than once a week. These separate out at all time points. They're separating. This is about a 41% difference in mortality which is about equivalent to that of wearing seat belts for 6 years. So they give you kind of a sense. Next slide. Now, sometimes religious struggle, and this is probably what many of us see here, when people are struggling with their religion, feel like God is punishing them, or, feel deserted by God. God has abandoned me. God is punishing me. God doesn't love me. Wondered whether my church had abandoned me. Questioned the power of God. When people are doing that and they're medically ill, it doesn't portend very well in terms of their physical health and ultimate survival. There is actually, this published in the Archives of Internal Medicine last year, 444 patients followed for 2 years. Mortality rates significantly higher. 6% increase in mortality for every 1 point increase on this scale that ranges from 0 to 21. Next slide. Further resources, the Handbook of Religion and Health. We already saw that. We talked about that. The link between religion and health. This is Oxford University Press. Came out in January, looking at psychoneuroimmunology and the faith factor. Spirituality in patient care. You guys have some of those out there? There's a little black book. Yeah. This is the most recent one out that includes the clinical applications. This has got kind of the research all summarized. If that big thick book, you don't want to go through that. This has got the research kind of summarized succinctly in a chapter. It has kind of the why, the what, kind of what do you do, how do you do it, when do you do it. Kind of, it has all the practical stuff in applying this to patient care. Parish nursing, this is a very rapidly growing thing. I don't know what's happening in Canada, but it's rapidly growing in the United States. 10 years ago, there were, I think, 2,000 parish nurses. Today, there's 8,000. It's gone from 2,000 to 8,000 in less than a decade. So this is Parish Nurses, a little book. It's kind of the stories of parish nurses. Psychology of Religion and Coping. This is by Ken Pargament, a Jewish man who has a very good handle of religion and coping, quite the opposite of Freud in that sense. The Healing Power of Faith is a popular book, easy to read, book. Most of these are my books, with a few exceptions. Timeless Healing by Herb Benson, the relaxation response. If you have patients who are not very religious, they're not attuned to this area, we'll say, hey, well, how about doing this relaxation response? It's kind of a behavioral medicine kind of a relaxation. And what Herb finds is that sometimes people they have these religious experiences once they get into these deep meditative states. It makes them more open, in fact, to more traditional forms of religion. Chronic pain, biomedical and spiritual approaches. If you have patients with chronic pain, this is kind of the updated medical treatments, surgical treatments, etc. This is coming out in February of 2003, actually. This is another one of my books. If you want to get on the web and get a nice review of this literature for free, you can download an article written in the Mayo Clinic Proceedings in December, and it's by Mueller. I have an editorial in there. And you can download those and just print them if you have the Acrobat reader. And it's a very nice review of the literature. Kind of summarizes the handbook in about 20 pages. Let's see. This is our website. This is a very deep website. It has all the books. You just click on it. You can get the books. It has 3,000 studies on it and reports, research reports, summaries of those 3,000 studies. Yes?
Could you read that off the tape?
Sure. It's the http://Garcia.Geri, Geri.Duke, religion/index.html. I'm not sure if you really need this. You know, if that doesn't work, just put in religion and leave this off. But it's got a lot of information, you know. Next slide. I want to give us some time here, at least a half hour. We've got to move quickly here. Here's this newspaper. If you want to be updated on the most recent findings that we've been talking about every month, 36 pages, you probably got a copy there. You can sign up for it for free. Go to the website, researchnewsonline.org, or I think there might be a little thing you can fill out. Then if you like it, you can continue it. It's $10 a year, like maybe $15 from Canada. $10 in the United States, $15 a year from Canada. Any international country. Actually, Sir John Templeton is supporting this newspaper. It's his brain, he's kind of the brainchild of this. And the subscription fees only pay for 5% of publishing and distributing this newspaper. So, you know, it's kind of a real deal. Next slide. Clinical applications. Let's go into this quickly. Prescribed prayer or religious beliefs. Well, my gosh, after hearing this lecture, maybe we ought to be prescribing religion to our patients, you know. Take a prayer, TID or whatever, go to church once a week. No, can't do that. Don't want to do that, wouldn't want to do that. Unethical to do that. So do not prescribe religion or religious beliefs to non-religious patients. Instead, find out what gives their life meaning and purpose and discuss that with them. Let them talk about that. Take a spiritual history on everyone, including people you don't think are religious. Take a spiritual history if it's only, how are spiritual things going? You know, how are things going spiritually? Sometimes I don't have time to do anything. You know, at the end of it, oh, how are things going spiritually? And they kind of know what I'm talking about. They say, oh, well, things are going well, not so good, or going good. Oh, I'm still, you know, still praying and doing that, etc. But sometimes that's all you have time for. But if you have more time, this is what is being suggested in the JAMA article. Christina also has a very nice history. Is she still here? No, she had to leave because she's getting up early. But she has a very nice one, the FICA, but this one is going to be in the JAMA article in 2 days from now. Does religion, spirituality provide comfort, or does it cause stress? Okay, you can do either. We know that religious struggle can cause stress. They're struggling with that. Are there any beliefs that might conflict with medical care? The Jehovah's Witness, the not accepting blood products, etc. How might your religious beliefs influence your medical decisions should you become seriously ill? Very, very important. Somebody gets on life support or has a feeding tube, their family may be praying for a miracle. They're not about to withdraw that feeding tube or discontinue that life support unless you know that. Unless you're communicating with that patient about it, you really can't even really practice good medical care. Is a member part of a supportive religious community? Very important. Any spiritual needs that someone should address. So this is very patient-centered. You can be any religion. Doctor can be any religion. Patient can be any religion. Somebody says, okay, take a spiritual history, fine. Okay, I worship the devil. Okay? You say, does your worshiping the devil provide comfort or cause you stress? Do those beliefs conflict with any of your medical care? How does that influence your medical decisions? Are you a member of a supportive spiritual community of other devil worshipers? Any spiritual needs that someone should address? So, you know, it makes no difference what your beliefs are. Those are the questions. Respect and support the beliefs and practices of the patient. Always. Always, that's number one. Whatever those, don't try to change them, don't try to manipulate them. Respect and honor them. Even if they're conflicting with medical care. Even if they're being used to justify non-compliance. You don't confront them necessarily and say, hey, are you nuts? What are you doing? You stopped your insulin. You ought to be on taking your insulin. You know, you're going to go into diabetes. No, you don't do that. What you do is you respect those beliefs and you learn about those beliefs. You try to understand. You get into the worldview of that patient. So you try to understand, why do they believe like this? Why have they decided to do this as opposed to, you know what, Jehovah's Witnesses? You know, it actually makes a lot of sense. You understand why they don't accept blood products. Their belief system is that if they accept that blood product, they risk eternal damnation forever. If you believe that, and you accept a blood product, or for your child, that means you could be eternally separated from that loved one if they die. You think about that. You know, it now starts to make a little more sense why they, you know, why those people would be afraid to, you know, accept those blood products. So you want to get into their worldview and dialogue with them in an honor, in showing honor and respect for those beliefs. Lithium anymore. You know, and especially after all the research you've done, you ought to for sure be, you know, in agreement with me on stopping this lithium. You're like, okay, fine. I'm glad that you've been healed. I'm excited about it. It's wonderful that, you know, that you've had this healing in your life. And instead of seeing you back in 3 months, I'll see you back in 2 weeks. You know, very simple. You just kind of monitor them, and when they start going downhill, they're more likely to tell you about it because they feel they trust you now, because you respect them. You know, instead of you challenge it, and then they have to defend their religious beliefs, which they're using defensively anyway. You know, but then they have to defend those, and then you're the bad guy, and then they'll just not comply, and you won't know about it. So get into dialogue with patients. Pray with patients. Praying with patients can be very, very powerful. Very powerful on the doctor-patient relationship. Can also get you sued. And people have been sued. Big suits for praying with a patient. Yes, mental health provider did it. In Texas, families sued, won. So there are precedents now, at least in the United States, in the legal system. So you take a spiritual history, there are certain framework about praying with patients. It's a religious patient. They would like you to pray with them. You know that from your spiritual history. You're the same religion as the patient. So you're not like, there isn't that sense that you might be coercing them with your religious beliefs. Patient requests. This is not always needs to be the case. You know, if you find that you have a very religious patient, you know they're going to appreciate it. The situation warrants it. You know, there's some stress there. I mean, you wouldn't do that on a wart removal, you know, or whatever. You do it, it'd have to be a serious, you know, something that there's some stress involved. Refer to chaplains always. Network with parish nurses and local congregations always. And I'm going to go through these next slides very quickly, and then we're going to open it up, and I'm going to answer questions. Next slide. Where are all those questions? We got them accumulated there? Good, okay. The elderly population in the United States. Now, I don't know what you guys have here in Canada, but we have got a lot of older folk, and there are going to be a whole lot more older people in the United States. Look at this rising in the demographics. Here we are in 2000. Look at what's happening with the elderly population. These are in millions. Next slide. Successful aging. Now take them big birds, Barney. Never eat a thing, just sit and stare. Next. Dang. Now where was I going? Superman in his later years. Next. Okay, now the United States is not the only country that's actually, Canada has more older people than the United States. Isn't that interesting? This is based on the United Nations population division. Canada has more older adults than the United States is ranked 33rd among developed countries. Isn't that interesting? And in 1999, 17% of Canadian population was over 60, 16% in America. So you guys have got, you know. Okay, now look at some of these countries. You think 43%, the entire population will be over 60 in European countries. Incredible. Imagine the healthcare issues. Next slide. I guess everything is relative. Well, I guess that ain't a bad story, but let me tell you about the time I lost this. So anyway, as I said, everything is relative in severity. Next slide. Okay, federal funding of health care. Now, this is the United States. I won't belabor this, but look at how much Medicare is increasing. This is 2000. Right now in America, you know, patients can't get a Medicare doctor anymore. I mean, you can't, doctors are not taking Medicare anymore. So you can't, if you don't have a Medicare, you don't have a doctor already is your doctor and you age into that doctor over 65, you can't get another doctor. This is where we are in the Medicare budget right now. Look at the projections in the next 10 years. Medicare spending will double, even with all of our cost constraints. Next slide. Oops. Now what this says, it says, let's see, you're a Medicare patient. Let me prescribe this prayer. So he is actually prescribing prayer. Next slide. And HMOs, this has been the United States' solution to the problem. My husband needed an expensive operation. You refused. He died. I think it's wonderful how readily you've grasped the concept of managed care. Next. Okay, now if you superimpose those increasing elderly population with the Medicare spending in the U.S., look at this. Look at how much Medicare spending is increasing at a time when the elderly population isn't growing that much. By 2011, there are no estimates of Medicare spending beyond 2011, and that's when this happens. You can see what a mess we're in the United States. Next slide. Now, this is a possible solution. Remember, son, it's never too late to start saving for retirement. There's Grandpa. There's his father advising him. Next slide. Before we try assisted suicide, Mrs. Rose, let's give the aspirin a chance. Next. And finally, United States and our President George Bush with his faith-based initiative. It's okay, we're faith-based. Next. Just various solutions, you know, that. Now, this is actually the solution that I think that we're really moving towards. And that is mobilizing our religious communities and connecting them with the parish nurse to connect the religious community with the healthcare system. The parish nurse is a person who mobilizes and trains volunteers from within the congregation who run these health programs and who provide these services, support, calling, visiting, patient advocate, etc., in the religious communities. And so, you know, by connecting, you keep people out of the hospital, and you also, keep people healthy by keeping them volunteering, etc. So anyway, next slide. That's it. Let me have these questions. Okay. Do we have lights on? Lights on. Good. Okay. What is the relationship between intercessory prayer and healing? Does the effect size increase with the number of people praying and length of time praying? Don't know the last question, if the effect size. Now, intercessory prayer is where people are being prayed for, but they don't know it. Okay? It's randomized, double-blinded studies where you have people praying for a group, and they don't know the people they're praying for, and the people being prayed for don't know they're being prayed for. So it's a double blind, which means the only way these people who got prayed for could have gotten better was either because of divine intervention or because, of positive thoughts. So the question is, what is the relationship between prayer and healing? Well, there have been about 12 studies looking at this connection, and about half find that there's a difference, and a half find that there's no difference. And the half that find a difference, the effect sizes are pretty small. They're probably, except for one study, they're probably minuscule, except for one study. This Columbia Hospital study, looking at fertility rates, finding that fertility rates were double among this study done in Korea by the Columbia University gynecologists, believe it or not, the obstetrics and gynecology department, Columbia University, New York, found a doubling of fertility rates. Double-blind, randomized control study. I don't understand it, but anyway, these studies I wouldn't rest my case on intercessory prayer studies, okay? I would not try to build your case on these studies because they are not based on any type of scientific framework, which means you'd have to overturn all of everything we know about the universe and about physics. And if they were true, there is no acceptable scientific framework. Now, yes, they're talking about certain groups say, okay, well, you have this quantum physics and quantum mechanics, and it's just not credible. There are no mainline scientists who would say that any of the theories that can explain intercessory prayer are valid. No mainline scientists. So there's no scientific reason for it. So that gives doctors and scientists problems. There's also a theological quandary, a real theological quandary with these studies. Because if you believe in a monotheistic worldview, there's less of a theological quandary in the Eastern worldview, because the Eastern worldview sees us all as connected, and potentially our positive thoughts could influence each other, etc. But in the Christian, Islamic, and Jewish worldview, it just doesn't fit God very well, okay? These studies don't really fit God very well. You can imagine, okay, you have half of this group that's they're going into intensive care unit. Okay, usually it's that. They're in intensive care. Now, first of all, half are getting prayed for, the other half are not. Are they really not being prayed for, that control group? Who goes in to have open heart surgery without somebody praying for them? Family member, themselves. Now, it's not a question of are you really testing prayer versus no prayer. Now you're testing more prayer versus less prayer. So now you have God counting the number of prayers. Okay, he has 6, the other has 7. 7 wins, I'll heal him. Also, this particular God only heals during the framework of the study. Study is 6 months long, that's when he heals. Doesn't heal later or, And his answer is always yes. It's always yes, and that's what you're testing, the yes responses. So it's never no. So kind of like a genie, that just kind of does whatever we bid him. So this is not the kind of God in the, any of the scriptures that Jews or Muslims or Christians believe in. So it really doesn't make any sense theologically. Anyway, okay, so long-winded answer to that one. Is there a gender difference, in medical practitioners regarding openness in addressing religious or spiritual issues? To my knowledge, there is not. To my knowledge, there haven't been many studies, but in our Duke study, we looked at, I think, 100 physicians. There was really no difference. Women physicians were no more open to it than were male physicians. And older physicians were less than younger physicians. So right now in the United States, 5%, about 5%, I would say, of doctors regularly address spiritual issues. About 5%. In the South, about 10%. It's 9% in St. Louis. But it's 5% regularly addressing spiritual issues. Now in Canada, to my knowledge, there are no medical schools that have courses on this topic. Somebody correct me if you know otherwise. There are no medical schools that have courses. The United States now, 70 of the 126 have courses on spirituality, religion, and medicine. So about 2/3 of the American medical schools now. So it is getting into the medical schools. They are getting exposed. And they are having conferences in Canada, though, that are addressing these. One was in Calgary, the next one is in Toronto. So there are these conferences for the medical establishment. But there doesn't appear to be, I would think there would be a gender difference, because every other population, I think the difference, there's no gender difference in well-educated professional women in openness. But there is a huge gender difference in the population. Women are by far more religious than men are. Church attendance, prayer, that's been replicated in every single national study that's ever been done. Women are much more attuned to these spiritual issues than men are. You go to church, you find that, at least 2/3 to 3/4 are women. That's just the way it is. Is that right? That's interesting. Maybe there's a genetic issue going on. Unbelievable. Okay. Has research distinguished between spirituality versus religion? If yes, how? Do they have a differential impact on positive health outcomes? Most of this research has not distinguished. Most of it is about religion. 90%. A few have looked at spirituality, and there are more studies coming out now, but we really don't know. We are starting to now look at this at Duke. We have about 850, actually nearly 1,600 now, where we have asked people to divide themselves up and say, are you religious and spiritual? Are you religious but not spiritual? Are you spiritual but not religious? Are you neither? So we're trying to look at that and see. We haven't analyzed this data. We do know, though, that at least among these older adults over the age of 50, about 80% are both. And about 10% are spiritual but not religious. Again, the well-educated tend to be spiritual but not religious. And then, the rest are divided among the other groups. We don't know if they have a differential impact on health outcomes. There is one study, though, that did look at this recently in Annals of Behavioral Medicine, February, did look at the differences in some health outcomes. And the spiritual but not religious group was not among the better outcomes. The best outcome was in the both group. So, whatever. That's just one study. Is there a bias in publication of research on the relationship on religion and health? If so, what is the nature of the bias? What about a publication bias? What about that? You know, what about? Well, I tell you what. If there was no relationship, then we ought to have as many negative studies as positive studies published, right? I mean, for sure, given that these are psychology and sociology departments, there hasn't been a love relationship between religion and these departments, okay? So they would be happy to publish negative findings. Certainly editors at journals would be, but you don't see them, or you see them very rarely. You either find, no relationship, or you find a positive association. And in our review, we tried to look at that. We tried to get everything that ever mentioned religion. I mean, if they just mentioned it for whatever reason and correlated it, whether they discussed it or not, and still, you still get these findings. So, I don't know. There has been in the medical journals, there has been a bias against publishing religious research. Part of it is because it hasn't been done very well. Most of it has not been done because there hasn't been any funding. Nobody's, until recent, there have been no grants to study this. And so people are doing it, on their off hours and on the side, so you can't really design a big study and really test this hypothesis very well. Okay. How do you distinguish between religion and faith? We really don't. We kind of lump it together. That's how our research has been. We try the intrinsic religiosity, the scale, the Hogue scale. Paul Tillich's definition of faith was the object of ultimate concern. The person's object of ultimate concern was their faith. Of course, faith can be in other things too. Faith in your money, your possessions, in the stock market, and your. People always, I was reading from Henry Nouwen. Henry Nouwen was, in Canada. Spent a lot. Henry Nouwen. Where was I going with that? What was I saying? Religion and faith, right? And Paul Tillich, the object. Okay, got it. Henry Nouwen said that human beings are worshiping creatures. We cannot stop it. We have to worship something. And if it's not God, then it's something else. And you look in every person's life, you will see that they worship something, whether it be education, whether it be their work, whether it be their family, whatever. We are worshiping individuals. That's what Henry Nouwen said. Great book. I was just reading it this afternoon. Something of a healer, suffering, wounded healer, right? Wounded healer. Okay, what studies have been done on the effectiveness of yoga and meditation on health and Eastern spiritual disciplines? There have been a number of those. Probably 20 studies so far have looked at meditation, transcendental meditation from the Buddhist perspective. No, mindfulness meditation from the Buddhist perspective, transcendental meditation from the Hindu perspective, lowers blood pressure, can lower cholesterol, and can relieve anxiety, reduce pain. My problem with meditation is that my mind's going too fast. I can't clear my mind. Also, I've tried to do it where I've tried to fall asleep. I'll meditate, and after about 30 seconds, I can't hardly even get through the Our Father. I'm just trying to say Our Father without drifting off into something. So, I just can't do it. But anyway, if you can do it, if you can continue to do it, persist in doing it, it can have health benefits. What are the physiological effects of belief in a grand, benevolent force? Maybe that's benevolent force, divine presence? What about the physiological effects of belief in a benevolent force, divine presence? I would suspect that, having those beliefs certainly would help to bring some comfort that there is, a force, a divine presence that is with one. I certainly would think so. I don't know if the Christian religious belief system has unique aspects to it or not. It might. I mean, part of it is this personal business, this personal nature of God. That God is a person, and you can relate to this person. With regard to loneliness, with regard to control, you can pray to this person who will, I don't know, I mean, it may or may not. Something to think about. Okay, what research has been done regarding connections between spirituality, religiosity, and development of positive mental health in children? Very little done in children, unfortunately. Kind of hard to measure religiousness and spirituality in children. I have a 7-year-old and a 13-year-old, and I couldn't imagine what question I could ask them that could tap their level of spirituality, but, they are being developed. Go ahead.
I don't know. I was looking at my own daughter, my own 7-year-old kid, and she believes with a faith that I'm ashamed of my faith. When I hear that kid talk about God, I really am.
Yeah. Of course.
And she just believes with her whole heart, and she got told to stop at kindergarten because she was trying to evangelize.
That's interesting. I don't know what it is. I don't know if it's genetic or not. Now we get back to the genes because it's
there. So it's there. The faith is there.
in some kids it's there, and some kids it just doesn't seem to be there. Yeah, it would be interesting. And the one person at Columbia University, her name is Linda Miller, is studying this, and she's developing the intrinsic religiosity scale, the Hoag scale, for children. She's trying to develop that for children, so we'll see what works out on that. But there's an embarrassing lack of research in children. Other than the fact that children or adolescents and teenagers don't use drugs and don't use alcohol as much as the more religious teens. Most of those 120 studies, in fact, were among young adults in regard to substance abuse. So that's a huge effect. How do you make religion useful without getting bogged down with the differences in belief? You see, when we did that spiritual history, it doesn't matter what the belief is. It doesn't matter what your belief is. It doesn't matter what the patient's belief is. So it doesn't get in the way of it. It really doesn't in the assessment process. We're not advocating that untrained health professionals give religious or spiritual advice to people. We really are not suggesting that. What we're saying is learn about it. Let them tell you about it. In fact, that's therapeutic for a lot of people. Just talking about their faith, their struggles. God doesn't love me. God's punishing me. You don't say, God loves you. That's not true. He loves you. You don't do that. You respect. You say, okay, well, why do you feel that way? Tell me about it. You relate to them. When Job's helpers, they were doing fine while they were sitting with them for 7 days. They were doing good. It's when they opened their mouth that problems started. So anyway. Comment on the use of health as a selling point for religion. That's a good one. As a selling point. Maybe this health-conscious generation of ours might turn to religion because it would offer them health benefits. Well, it could definitely cut two ways. First of all, there are no studies that show that if you become religious only to be healthier, it's going to work. There are no studies that show that. If you go to churches because you think it'll make you live longer, that it's actually going to do that. For somebody who doesn't want to be in church, that might actually cause stress and cause them to live shorter. So the studies show that if you're religious for religion reasons, you have better health, not the other way around. So I'm not sure if it'll work. Is there evidence of a differential effect of religion on various types of health? It looks like the stress-related illnesses, like cardiovascular disease in particular, seem to be a greater effect. Looks like in some of the sub-analyses of actually the West Coast studies, Doug Ullman in the Alameda County study looking at survival, it looks like those cardiovascular disorders possibly, I'm not sure, it's cardiovascular and pulmonary disease. I think those are the big ones, and that's controlling for smoking. So anyway, the stress-related ones. Okay, we're almost done here. Roughly, what are the conditions which increase the likelihood of toxic reaction to religion, or at least immunity to its normal benefits? Any personal factors? Okay, that's good. What is, well, certainly people who are really, really rigid in their belief systems, who just are not flexible, have kind of a religious beliefs that isn't really based upon love of neighbor and love of God. There's all sorts of religions that kind of drift away from that kind of basic element. Love God with your whole heart, soul, and mind. Love your neighbor as yourself. Religions that get on to the more legalistic stuff and the condemning others, that's not so good, I don't think. Although, who do you think are the most optimistic, the most positive, the most optimistic of all of the religious denominations? Who do you think it is? You think it's the Methodists, Catholics, Lutherans, fundamentalists? On the evangelical, conservative, fundamentalist spectrum, the most optimistic. This is actually the president of the APA, E.P. Seligman, is the person who demonstrated that. He has 2 papers on that. And apparently it's because, their songs are very, very positive, very optimistic. And the song, the liturgy, the sermons are all talking about, salvation and being freed from, very positive. So anyway, interesting. What aspects are more helpful, spirituality, than others? It's that religious community involvement that is the one we can show it in. I think you really do need the both. If you look at that slide there, you can kind of see those with both the intrinsic, both the private religious activities suggesting personal and the religious communal involvement have the most benefit. This is also true in the Jewish population study with the coronary artery disease. That orthodoxy scale was made up of the personal religious practices and attending synagogue. So it looks like the personal and the communal are very important together. Okay. How are we all doing here? I see some people fading off here, and how are we doing here? It's 5 after. Let's do a couple more, and then we'll close it out. How can the public sector agree on whether to use spirituality, and if so, how, to promote public health, including peace, not just cure illness? Yeah. How can the public sector agree on how to use spirituality? Well, I think, again, in the States, we have this faith-based initiative. And what we're trying to do is try to take advantage of religious communities and the volunteers within communities to help with substance abuse. This is where it's starting. And then the next is going to be mental health services with faith communities offering these mental health services. I think the next is going to be providing of health care services. So mobilizing people who are in religious congregations both in terms of health maintenance and disease prevention, as well as providing health care to those in need within the congregation. I think that's the way it's going to be mobilized on the public health sector. Okay, last one. How do I tell people in my church, the believers, that indeed a connection exists between religion and health and research? Well, what you do is you buy them one of my books and hand it out, and that's a good way to do it. So, very good. Thank you for asking that question, actually. Let's see, one very last interest in research on well-being. What are the research findings? Okay, we kind of answered that. What about non-believers, agnostics? I think non-believers, agnostics can derive benefit from meditation. I think that can help them. That non-religious, you can repeat, you can repeat money over and over again if you want. You choose any sound or phrase, repeat it that's special to you. I mean, you don't have to choose money. You could choose, the name of your daughter or whatever you value and you find meaningful. You would use that word, you repeat it slowly, clear your mind, and yes, I think you would derive some benefit from that if you can keep doing it. You've got to keep doing it. See, the problem is when that is divorced from everything else and you're just doing that, you stop doing it because you don't have the social reinforcement. But if you can do it on your own and be self-disciplined, it can can be very helpful. Okay, I'm going to release you all. I got to get up at 5 a.m., so I'm going to bed. Thank you very much.